We are going to break up Chapter 30 to discuss the types of fluid most commonly seen in the hematology lab. We need to discuss the sites of origin of body fluids and the procedures needed to obtain that fluid. So when we're talking about anatomical sites, we're looking at the pleural, pericardial, and peritoneal spaces being the serous fluids as a group. So for pleural cavity, this is the lung fluid. The procedure is called a thoracentesis, and the fluid obtained is pleural fluid. Similarly, with pericardial fluid or cavity, this is this sac surrounding the heart. So the aspiration process is a pericardial aspiration. In the peritoneal cavity or the abdominal cavity, the procedure is a paracentesis where they pull out ascitic fluid or peritoneal fluid. Now you can have any kind of joint aspirated, which is called an arthrocentesis. Okay, a lot of the times when people have injuries, they get fluid removed from the knee, from the elbow, or from the wrists, depending on what joint is inflamed. The spinal cord is a lumbar tap or lumbar puncture, and here we get fluid obtained, which is cerebral spinal fluid. Now here's a diagram of the lung. So on the left-hand side, you have a normal lung that is visible to you, where you have the lung surrounded by a cavity, and within this cavity, in its sac, you have fluid. And in here are lining of those mesothelial cells that we saw in the body fluid differential. On the right-hand side is where you have a pleural effusion. That means a buildup of fluid that is pushing or compressing your lung upwards due to some kind of problem or inflammation. So here, with this effusion, we take an aspiration of that and send it to the lab for analysis. Now here is a picture of the abdominal cavity that is illustrated by the peritoneal space. This is between the inside of the abdominal wall and the outside of the liver, stomach, intestine, and the dome of the bladder. Now here, these serous types of fluid are similar in structure and function. They have small spaces that contain minimum amount of fluid to keep the membranes moist and soft. So the inner membrane is called the visceral membrane, and the outer is the parietal membrane. Now accumulation in this space can be quite large, and if it is an effusion in the abdominal cavity, it could be considered as ascites fluid. So now let's classify the types of fluids that could be removed from the serous fluid cavity. So effusions are classified into transudates and exudates. A transudate is a fluid accumulation from some kind of systemic disease, whereby an exudate is a fluid accumulation from some kind of pathological state of the area. So when we look at these types of specimens, we have to see their characteristics. So a transudate is non-inflammatory. The specimen typically looks clear or very pale yellow. And usually there are very few cells here in some degree, whereas exudates are usually due to some kind of inflammatory process where their specimens usually look cloudy, yellow, or bloody. And in these instances, you have very many cells, and the joints or spaces are also very inflamed. So here we have a physical sample of two CSF specimens. The one on the left is showing xanthochromia, and the one on the right is clear and colorless, the type of specimen we want to see from a CSF. There are a couple of reasons why CSF is tested. First, to identify if there is any kind of meningitis, and that is the inflammation of meningeal membranes due to some kind of bacteria, virus, or fungal infection. The second reason to test CSF in the lab is to detect any subarachnoid hemorrhages. This is bleeding into the space between the arachnoid membrane and the pia mater, which increases red blood cells in the CSF, but you have to ensure you do not have a traumatic tap. Each lab receives 4 tubes of CSF. They are marked 1 through 4 and are delivered to the respective departments labeled by the tubes. If the tubes are consistently bloody all the way through, you can ensure that the patient has a subarachnoid hemorrhage. If the specimens decrease in their bloody appearance, then you can assure that that was a traumatic tap in the procedure, that was a procedural error. There have also been tested CSF for any kind of malignancies, often due to a metastatic disease, as well as detecting demyelinating neurological diseases. So let's talk about the synovial membrane. The synovium is a special membrane that lines some bony joints. It's made up of a layer of single synovial cells that produce an ultrafiltrate of plasma. The point is they serve as a lubricant and transport membrane for nutrients. They contain hyaluronic acid, which makes the fluid very viscous. Now here we have certain kinds of joint diseases that occur with the joint spaces and are classified into 4 categories. Now here is the diagnostic joint fluid group classification. So normally in synovial fluid, the normal color is pale yellow, clear, and viscous. As you're seeing the groups, one being non-inflammatory due to some kind of traumatic arthritis or osteoarthritis or some kind of joint disorder. Group 2, we begin to get into the inflammatory kinds of condition of rheumatoid arthritis, lupus, and other kinds of immune disorders. Group 3 is a septic type of infection, and these will be hazy or cloudy and most likely caused by bacteria, fungi, or mycobacteria. Group 4 are crystal-induced, where we see multiple crystals coming out in the specimen as well due to gout or pseudogout. And Group 5 is a hemorrhagic type of diagnosis where you have some kind of traumatic injury or some kind of bleeding disorder, and here you're going to see the specimen being completely bloody. Another type of specimen often seen in the hematology lab is a bronchoalveolar lavage. This is obtained by rinsing the alveolar and bronchial air spaces with saline. Then there will be a cellular harvest and non-cellular elements of the lower respiratory tract. Now this is very valuable in diagnosing interstitial lung diseases, infections, and malignancies. The type of cells present are more important than the cell count. Normally, you would see greater than 80% macrophages and very few lymphocytes. Here we see normal existing cells that are found within these fluids. So in the CSF, the only cells that are normally found would be any type of lining cell due to the tap. For your serous fluids, which are pleural, pericardial, and peritoneal, we're going to see the mesothelial lining cells. And for your joints, you'll see various synovial cells and the bronchoalveolar lavage bronchial cells. These are all different types of lining cells within the joints. The only one that you'll be able to identify or that you have been introduced to are mesothelial cells, because the serous fluids are the most common type of body fluids collected, and as for entry level, this is how you have to identify these lining cells. Now let's talk about the physical characteristics of body fluids, and we're going to start with serous fluids, as this is the first type of physical property you are going to evaluate as a CLS. So normally it is clear or pale yellow. We've already talked about the plural transudate and exudates and the differences between those two fluids. Now there could be a cause for blood within the pleural aspirate, which could be caused due to some kind of cancer. You may also get chylous pleural effusions, as you see in the middle, which are resulting from the leak of lymph vessels of the major thoracic duct. Or it could be a blockage from lymphatic vessels in peritoneal fluid. You'll see it's milky or opaque in appearance, and it remains in the supernatant even after centrifugation. Now, effusions can result by trauma or malignancy because they're rich in chylomicrons and triglycerides. Now here, normally lymphocytes would predominate. Here are the physical characteristics of the synovial fluid based on the classifications of group 1 through 5, where you'll see the traumatic level 5 bloody sample, and stage 3 the bacterial opaque hazy sample. Number 1, non-inflammatory, 2, inflammatory. You start to see a little bit of that pale yellow color. The second portion here is your cell counting using a hemocytometer, and you're getting used to the calculation here of the average of the cells on both sides of the hemocytometer times the reciprocal of the dilution over the number of squares on each side times the area and the depth. Now the depth can be either on the top or the bottom of the calculation. When you're talking about the cover slip depth, if you're putting it on the bottom, you would be dividing it by 0.1. If you were using it on the top, you would be multiplying it by 10. Now let's talk about some reference intervals and disease correlation with the CSF. Normally, for adults, you can have 0 to 5 WBCs. For neonates, it might be a little bit more increased due to some kind of trauma they're having during childbirth. Children to 1 year old can see some cells of 0 to 20 within the meninges. Those are white blood cells. And usually the reference ranges range from 1 to adolescence being 0 to 10, and predominant cells being the monocytes or the lymphocytes. For serous fluids, normally you're not going to see any red blood cells, and you may see less than 1,000 microliters of white cells as a total count. Predominantly, you're going to have mononuclear cells like monocytes, histiocytes, macrophages, and some lymphocytes, a few of the lining mesothelial cells, and here your total nucleated count should be less than 200 cells per microliter. As for the bronchoalveolar lavage, your concentration depends on the volume of fluid infused with the returning yield based on the procedure. So normally you have a nucleated cell count of 100 to 400 microliters, but anything microscopic is more important than the count because here we're really looking for any type of malignancy. Now, some cells that are common to all body fluids are segmented neutrophils. So the differences that you saw are some artifactual changes due to cytocentrifugation, where the neutrophils look hypersegmented, and they could also start to degenerate where you see vacuoles and separation of those nuclear segments that stain very dark. You may also see some immature neutrophils such as bands as a common body fluid cell. Now here the arrow is pointing to a degenerated neutrophil. So first, as they become degraded, they start to windmill around the edge and the lobes start to separate, and then each of those lobes will filament, will start to condense and become little balls. This is a necrotic neutrophil in the middle. Now here is a lymphocyte with some artifactual changes. So it looks like there's cytoplasmic projections going out through the back of the cell. This is normal when you're looking at body fluids, again because they're lacking the nutrients that a normal blood peripheral specimen has. Here we see some monocytes in the picture here. And again, they're going to be classified into the monocyte macrophage classification. Here is a histiocyte. It is a very large cell. The arrow is pointing to the vacuoles seen as well as the eccentric nucleus moving to the edge. A macrophage here, you can see the debris that is collecting into the cytoplasm, again classified as the same cell, and the nucleus is moving eccentric into the edge of the cell. Look at the macrophage compared to the red blood cell right next to it and see how large these cells can become. Now here's what a reactive lymphocyte looks like in pleural fluid, and below it you have a normal lymphocyte. So you can see that it's larger and the cytoplasm is quite a bit darker. You can also start to see some bacteria, which is extracellular or intracellular inside of that neutrophil in certain types of joint fluids that have infections in them or are inflammatory. And here is a benign mesothelial cell within the pleural fluid where they stick together. They have a very circular nucleus and a fuzzy outer edge. These are normal lining cells within the serous cavities. Here are reactive mesothelial cells, and you will really have to identify the normal mesothelial cells, as reactive cells will not be asked of you, but you can see how different these cells are from the other one, as they are very dark in color and irregular.